Bennett broadcasting from Miami. Tonight we have continuing the series of education hangouts with Dr. Abdul Rana, a neurologist and a world-renowned Parkinsonism educator from Toronto, Canada. And tonight we're covering the topic of depression and Parkinsonism. Good evening, Dr. Rana.
Good evening, Dr. Bennett.
Has
It's
the
nice
snow?
to talk about Parkinson's.
Yeah, is the snow stopped up there in Toronto?
Oh, yes, it's getting much better.
Finally, huh? Okay, let me start off, Dr. Rana, by asking you, how is depression related to Parkinsonism?
About half of patients with Parkinson's, they do develop symptoms of depression at some time in the course of disease. Most patients have anhedonia, lack of initiative, and assertiveness. Some patients may have dysthymia, which is, in simple terms, you can say a milder degree of depression. Uh, However, other patients may meet the criteria of major depression sometime in the course of disease. Patients may have lack of interest, fatigue, lack of energy, indecisiveness, sadness, and sometimes symptoms of depression may precede the motor symptoms of Parkinson's disease by many years. And they may go unnoticed. The risk factors for depression in patients with Parkinson's disease are about the same as in other people. Increased age, female gender, and family history of depression are the risk factors of depression for Parkinson's disease patients. The pathophysiological basis of depression in patients with Parkinson's disease is same as in patients who have depression without Parkinson's disease.
Well, you know, doctor, a quick question. Have you seen, or do other doctors see a patient that's depressed and they refer them to a neurologist and he finds out it's Parkinsonism? Does that, and you said it comes before sometimes the motor symptoms, correct?
No. There are patients who see a neurologist and they are referred for Parkinson's, but when you review their history, they have had depression for so many years and they have been treated for depression as well. But at that time when they were diagnosed with depression and were being treated, they did not have any symptoms of Parkinson's disease. And there are some other patients who see a psychiatrist for depression-related symptoms and they do notice some motor slowness and facial masking and other milder symptoms of Parkinson's, and this is how they get referred to a neurologist.
Wow, so they're referred from a psychiatrist sometimes.
Yes, it could be from psychiatrist, sometimes from family physician, and other time they may be referred from family physician, but they are seeing a psychiatrist independently with the remote history of depression.
Very good. What is the exact mechanism of depression and Parkinsonism?
The exact neurophysiological mechanism of depression in Parkinson patients is unknown, but most experts think that it is due to involvement of multiple neurotransmitters. So there could be deficiency of the dopaminergic projections as well as noradrenergic and serotonergic projections. The loss of dopaminergic projections in the ventral tegmental area and the orbitofrontal area, it leads to apathy and abulia, which are common symptoms seen in Parkinson's disease patients. And also some studies have shown decreased binding of 5-HT1A receptors in limbic cortex as well as frontal and temporal cortical areas in Parkinson's disease patients, so which is an indicator that these patients with Parkinson's disease, they have not only deficiency of the dopaminergic receptors, but they also have deficiency in the non-dopaminergic, such as adrenergic or serotonergic projections, which leads to depression in these patients. So it is likely multifactorial.
what are some treatments which can be used for depression and Parkinsonism?
Uh, uh, Say it again, please.
What are some treatments which can be used for depression
Right.
and Parkinsonism?
Right. With respect to treatments, it's very individual and varies from patient to patient. The physician has to screen the degree of depression and the phases in which depression occurs in these patients and the timings. Because some patients may have depressive episodes when they have off periods. When the effect of levodopa wears off, these patients feel depressed, but otherwise, when the levodopa is working, then these patients don't feel depressed. So in such population, you just need to address those off periods. If you adjust the dosage or frequency of levodopa, or if you add certain medications which may prolong the half-life of levodopa, then you can improve depression in these patients. In other patients, traditionally tricyclic antidepressants have been reported to have beneficial effect, but the first choice treatments are usually SSRIs. So the medications like sertraline, fluoxetine, paroxetine, these are the first line treatment in these patients. And some patients may benefit from the dopamine agonists. Sometimes we start dopamine agonists in patients to help the motor symptoms of Parkinson's disease, but these patients do feel better in terms of depression. So some of the patients may not volunteer the information. They may just attribute their symptoms of depression to various stressors in their life, or just age, or being alone or isolated. So you have to really tease out how much feeling of sadness or lack of interest they have, and you may have to screen for other signs or symptoms of depression, such as their increased or decreased sleep, or early morning awakenings, a decreased energy level, or a feeling of fatigue or worthlessness. And some patients may have decreased concentration. They may have difficulty with decision making or thinking. At times the appetite is changed, or patients have change in weight. Some patients have decreased psychomotor activity, others have increased, and a small number of patients may have suicidal ideation, although it is much less common. So these patients should also be screened for visual hallucinations and delusions. So then, accordingly, when you see various symptoms which may indicate the underlying depression, you try to address them, because sometimes you may need to address the motor part of the symptoms, and by adjusting the dopaminergic medications. At other time, patients may be doing reasonably well with respect to motor symptoms, and you may need to use SSRIs. And sometimes just using non-pharmacological treatments may be helpful. Some of the studies did show that the suicidal or death ideation is less common in patients with Parkinson's disease. Other studies have shown that the suicide itself, although reported in Parkinson patients, but it is less than general population. So in literature and among experts, this is a debate and somewhat controversial findings by various studies. So you need to address these issues very clearly with patients. You have to ask them very direct questions about these symptoms. So if patients have just decreased motivation and lack of initiative or decision making, which you may find out when you're doing history taking or examination. Suppose after history taking, you are asking patients about the choices of treatment, or even during history when you are asking questions, So sometimes they may look towards their spouse to answer the question. So they have these this decreased motivation and lack of assertiveness. Some physicians refer this to head turn sign, that they may look for answers toward their spouse. And also when you discuss treatment options, they want their spouse or caregiver or significant others to make a decision for them. So from there you can assess that these patients they really have lack of motivation, and they should be further screened for depression. The patient as well as physician and the caregiver, they have to be very vigilant about these symptoms of patients, and the physician should also try to identify if there are any life stressors which are causing a situational depression. Sometimes patients may have a reactive depression with the diagnosis. At other times, if their symptoms take a downturn or they deteriorate relatively subacutely, they may feel quite depressed. Some of the symptoms, such as drooling or urinary incontinence, they may make patients less sociable with other people, so they may lead to a reactive depression as well. So daily exercise does help with patients, so we usually discuss with them to engage themselves in a routine daily exercise. In addition to this, we usually try to optimize their dopaminergic treatment, and also we need to assess whether we need to add any other medications in addition to dopaminergic medications, which can provide a boost to these patients in terms of physical as well as emotional well-being. As I said before, the SSRIs still remain the treatment of first choice in these patients. Sometimes the question is raised about the motor worsening with SSRIs. Some physicians might think that the patients may have more bradykinesia if you treat them. Usually motor worsening is not significant with SSRIs. In the past, there have been reports of using ECT, the electroconvulsive therapy, as a treatment for major depression in patients with Parkinson's disease. So currently, most experts think the evidence for its safety and efficacy is not sufficient. So at this time, it is not an agreed upon treatment and is not used routinely in most Parkinson's clinics. So in addition to this, these patients should be assessed for cognitive function as well, because depression can affect the cognitive performance. So once a physician understands that the patient has underlying depression, so they should have the cognitive assessment, which is a detailed testing of various domains such as memory, executive dysfunction, as well as visual-spatial functioning, so that these issues can also be addressed.
Very good, Doctor. One question. Do you feel comfortable treating the depression in a patient with Parkinsonism, or do you refer them to a psychiatrist?
Yeah. Usually, those physicians who have been dealing with Parkinson's, they usually treat depression themselves in patients. There are several reasons for this. One is they feel comfortable because they have been dealing with this over some time. So, and if the depression is mild and there are no major issues which could be risks to safety, so then it's quite straightforward to treat these patients. So you have to discuss with the family member or a caregiver as well. Sometimes we do need help of a psychiatrist if patients have psychosis, depression, and other psychiatric symptoms such as anxiety. So at other times, to get an appointment with the psychiatrist is not easy either. So patients may have to be subjected for a long waiting time. So you may initiate the treatment, and at the same time you may refer them to a psychiatrist. By the time they see psychiatrist, they have some improvement, and if psychiatrist wants to modify treatment, they can do that at that point.
Very good, doctor. Anything else to add?
The depression does remain underdiagnosed in these patients, especially because they are elderly. Sometime they could be living alone, and they could have their kids who are living at a distance, or they are visiting them on the weekends, so for a short time, and they can't really estimate if these patients are subjected to depression. So depression should be the part of the routine inquiry of Parkinson's disease patients. So because it does make a great difference in the quality of life of these patients.
Very good, doctor. Thank you very much for a complete overview of depression and Parkinsonism, and we look forward to the continuing series on Parkinsonism TV. Good evening.
Sure. Thank you very much.
Thank you.